Okay, welcome everybody. We are going to start our lecture of respiratory drugs and corticoids. Today we are going to talk about chapter 36, antihistaminics, and chapter 37, respiratory drugs, according to our book. So let's start with the first slide, just to give you an idea about the respiratory tract infections and respiratory tract treatment. First of all, there is some NCLEX questions that always are coming from the NCLEX exam. That is actually where is coming from the mucus of the bronchi and the trachea. So before that, I would like to tell you that there is different talking about anatomy, physiology a little bit. If you take all the alveoli together and put it like a carpet, they are going to have actually the size of a tennis court. So this area of tennis court is the area where you are going to have the gas exchange. We have, and we will see some examples in the we are going to talk a little bit about anatomy physiology. All right, so let's continue. So, by the way, we have in each lung, we have about 300 million alveoli in every single, in every lung. So we have about 600,000 to 700,000 alveoli in the respiratory system. All right, so here we have a very brief, just to remind you that we are going to classify the respiratory tract in the upper and the lower respiratory tract. Upper and lower respiratory tract. The upper go up to the larynx, so up from the nasopharynx to the larynx, and that is the upper respiratory tract. Below that, the trachea start with the lower respiratory tract. They go to the bronchi, and they go to the alveoli. So why I'm doing this differentiation? Because the pharmacology that we are going to talk today are going to be related to the upper or the lower respiratory problems. So ahead of time, I'm telling you that we have 7 group of medications that we are going to memorize, or go through this class. All right, so just remember respiration and ventilation. What is the difference? When you are talking about ventilation, it's the process of moving air from in and out of the lungs, so it's the movement of the thorax, in other words. And respiration is the gas exchange. So respiration is going to be assessed by the saturation of oxygen. So that is what we need to just remember. All right, so let's start talking about the upper respiratory tract and lower respiratory tract. Very simple. So what we need to remember is that this epithelium of the respiratory tract coming from the trachea and the bronchi, they are going to have mucus. These mucus are coming from the goblet cells. So always in NCLEX, believe it or not, they're asking about the goblet cells. So those are where is coming all the secretions of the respiratory tract. Right, so not to go into much detail, so let's go our topics. We have the management of the respiratory problems or infections are going to be, first of all, environmental control and pharmacological management. So pharmacology is the class today, and we are going to talk about, first of all, antihistaminics. You start to think about why do we need to use antihistaminics, or when, what are the side effects, decongestants, or we can use both. And there's other that can be used as intranasal steroid spray, that they have several nursing considerations. All right, so pediatric concerns, the FDA do not use OTC cough and cold products in less than 2 years old. So that is something that is really important, because they can lead into oversedation, they can produce seizures, tachycardia, or even death of the toddlers. Okay. All right. So let's start talking about our signs and symptoms. Why signs and symptoms? Because that is the treatment. That is what we the medications that we are going to use. So how many groups of medications are going to be? 7 groups of medication, 7. And from this, we are going to divide signs and symptoms, because mostly of the upper respiratory tract problems, they are going to be symptomatic. And so symptomatic means that it's not going to cure the process, but it's going to control the process. And we are going to have congestion, cough, and mucus. So we have congestion, cough, and mucus. So just to go faster later on, so we are going to see that the congestion is when the vessels are being vasodilated because the histamine. The histamine, let me see if I can have my pointer. Just a moment. Okay, so congestion is when you have, for example, a vessel. This is a normal vessel. The vessels are going to vasodilate. It's going to be vasodilated. When this vasodilation happens, water are going to escape from the vessels, are going to produce accumulation of fluid around the mucus, for example, the nose. And you can tell the mucus are going to be closed because the mucus are so swollen that they are going to prevent the entry of air. So who produce this vasodilation? These vasodilation are basically given by the histamine. The histamine. The histamine is a potent vasodilator of the vessels. So that is going to lead into the increase the congestion, because that produces the exit of water from the vessels. All right, so for congestion, we have the pseudoephedrine. And the pseudoephedrine, as you remember, are actually an adrenergic medication, adrenergic. So these are mostly alpha-1. That's what we need to remember, alpha-1. What is alpha-1 doing? Remember, alpha-1 produce vasoconstriction. Alpha-1 produce vasoconstriction. Example of this is the pseudoephedrine. We have the antihistaminic. The antihistaminic is for congestion. Obviously, if the histamine is going to produce vasodilation, as a consequence of this vasodilation is going to produce escape of water and produce edema, congestion. So we can use pseudoephedrine, that is alpha-1 agonist, and antihistaminics in order to prevent the congestion. Okay, so which one is going to be faster? Actually, the pseudoephedrine, alpha-1. Alpha-1 is the Sudafed, right? Remember the Sudafed? Okay. All right, so another sign, we have cough. Cough is going to, we are going to use antitussive, that is prevent the coughing, okay, prevent the coughing, and that is the dextromethorphan, antitussive dextromethorphan with T, that is going to be used for, as antitussive to prevent the cough. So when is going to be used, this dextromethorphan? If you know that the cough is a mechanism of protection, they are going to get rid of the bacteria through the coughing. When the cough is actually dry cough, you are not actually, we are going to use antitussive. So this dextromethorphan. Why? Because if this is productive cough, we don't want them to suppress the cough, because if there is productive cough, we are going to try to get rid of the mucus. Then we have the mucus, another signs and symptom. And this mucus, we have the expectorant, that is the opposite of the antitussive, that is the guaifenesin. This guaifenesin, and we have the mucolytic, the acetylcysteine. All right, so let's focus a little bit about this here. So we have number one, increase of mucus, right? Increase of mucus. When you have this increase in mucus, you can give guaifenesin or you can give acetylcysteine. Guaifenesin is OTC. Guaifenesin is by prescription. Okay? Acetylcysteine is by prescription, and the guaifenesin is going to be OTC. What is doing this? What is the difference between expectorant and mucolytic? Expectorant means that you are going to get rid of the mucus, right? And mucolytic means the same. So what is the difference? Expectorant is, if you have the mucus here, this is the mucus, this is the mucus. The mucus is going to be formed by a protein that is called the mucin. The mucin. This is a protein that is going to be in the mucus. So what is doing guaifenesin? What is doing acetylcysteine? Guaifenesin, what is doing is bring water into the mucus. So if you bring water into the mucus, what is going to happen? The mucus become more fluid, right? And that is going to be easier to get rid of. And the mucolytic, that is acetylcysteine, what it's doing is to break down the protein called mucin. So there is two different mechanisms of action that they have the same function. So they are mucin. So acetylcysteine is going to break down the protein of the mucus, and that make the mucus more easy, more fluid, more easy to get rid of. Okay. So we have signs and symptoms. So for each, remember symptomatic, for each sign and symptom, we are going to have some medication that is going to be symptomatic, means that are going to control the signs and symptoms, but not cure the problem. Okay. All right. So let's keep going here. There is some question here. The common cold is treated with empiric therapy, which means that the medication only treats symptoms. So it's the same thing that we was saying in the previous slide, but here is actually in different words, right? The common cold, when you're talking about common cold, you're talking about the upper respiratory tract. So here we have the mucus. We have the mucus. We have congestion, and these two are going to be seen in the upper respiratory tract. Mucus, we are going to use expectorant, okay, antitussive. Expectorant, who is the expectorant is the guaifenesin. Antitussive is the dextrometorphan with T. Guaifenesin do not have T. So antitussive have two T's here. Dextrometorphan are going to, just remember, is going to be to control the cough. Mucolytic is the acetylcysteine. Congestion, we are going to have decongestions, for example, alpha-1, and we have antihistaminic. So all these two are going to be for upper respiratory tract. The bronchodilation and the anti-inflammatory are going to be mostly used for a process of asthma, emphysema, COPD, and those guys are actually from the lower respiratory tract, and we are going to see each of them. Okay, so decongestant, what it's doing is we have the pseudoephedrine. It's going to make, if you see, this is the vessel that is dilated. If you have alpha-1 decongestant, the vessel becomes vasoconstricted. So that means that the water is not going to go out of the vessel anymore. So that is going to decrease the congestion. Antitussive is going to suppress the coughing, and please, this is, I want to have 3 stars, 4 stars, open eyes, open ears. Here, antitussive, what is the cough center? The center of coughing in the body is the medulla oblongata. Medulla oblongata. Okay? Medulla oblongata is the center of the cough. We have the mucolytic, this acetylcysteine, that is going to produce the breakdown of the protein. The protein called mucin is going to get are going to be dissolved, and that makes the mucus easier to get rid. Antihistaminics, we have the first generation and the second generation. Open eyes, 3 stars, 4 stars here. We are going to see that first generation we have the Benadryl. The Benadryl, and one of the first the most common question for NCLEX is that they can produce drowsiness, drowsiness, drowsiness. First generation, Benadryl. Just remember, BED. You go to bed because you can actually, you feel drowsy. Plus, another thing I want you to remember about Benadryl. Benadryl, if you see here, DRY, 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 this dryness. So these antihistaminics can produce dryness of the mucus. So you need to be careful because in kids, in children, they can produce the mucus totally become like a gum, totally hard. So in this case, what you are doing is to give a lot of fluids, PO, to the patient because you don't want to get dry those mucus, and when they get dry, they can produce, they can be a focus of infection. Okay. All right. So second generation loratadine is the Claritin. Claritin is still OTC, and this Claritin second generation. You remember the pharmacokinetics and the pharmacodynamics are going to be obviously better in the second generation antihistaminics. So that means that they have, if drowsiness are going to be +3, for example, in the first generation, drowsiness is going to be +1 or none. So that is the Claritin. Better pharmacokinetics, better pharmacodynamics. Pharmacokinetics means lower dose, for example, and pharmacodynamics means less side effects. We have the expectorant, we have the guaifenesin, that what is doing is, if you have the mucus, this is the mucus, that is going to bring water into the mucus, so making the mucus more fluid. All right, so that is, in the previous one, we was talking about the upper respiratory tract, decongestants, antitussive, mucolytics, antihistaminics, and expectorants. Then we have in the lower, for the lower respiratory tract, for example, we have the asthma, we have COPD, we have emphysema, we have atelectasias, bronchiectasias, etc., where actually the respiration, the oxygenation of the body is going to go down. So for that, what we are going to use is, for example, bronchodilators. And there's many things that we need to talk about that. And anti-inflammatories. So please, I want just you to remember always about these anti-inflammatories when you're using steroids, leukotrienes, and mast stabilizers. So first of all, leukotrienes are part of the prostaglandins, right? And that produce inflammatory process. So remember the prostaglandins, they have inflammatory for pain, for clot, right? And produce mucus. So that actually the leukotrienes are going to just block this inflammatory process. So mast stabilizers are the mastocytes, mast cells. These mast cells are going to come from the red bone marrow, and they are going to produce histamine. Okay, so you can tell histamine, what it's going to do is produce vasodilation. So if this is the trachea, the histamine is going to produce a vasodilation. The mucus start to have edema. So can you see the lumen of the trachea is going to diminish? And what is the sign of this? Is going to be wheezing. All right, so here we have steroids, leukotrienes, and mast stabilizers, and these, all of these are not going to use for acute process. There's not use for acute process. They are going to use to control the recurrency in the long run of asthma process, and it's going to take about few days, even weeks, in order to make effect. So this, if you have a patient with acute respiratory distress because of asthma or whatever, COPD, this is going to control, but in the long run. What we are going to use in and is going to act very fast, are going to be the bronchodilators. the bronchodilators. The first one and the fast acting is the albuterol. Albuterol. What is the albuterol? Albuterol is beta 2. Beta 2, you already know. I don't need to say agonist, right? When I said beta 2 only alone, that means beta 2 agonist. But when I said beta 2 antagonist, I need to say antagonist always. In this case, albuterol is beta 2. That means beta 2 agonist. We have the anticholinergics that you already know. For example, the acetylcholine. Remember, acetylcholine. The opposite is going to be anticholinergic. But let's start with the acetylcholine. Acetylcholine is going to remember the increased pee, increased poo, and saliva, right? So everything that is wet is going to be acetylcholine. So these acetylcholine are going to, in addition to that, acetylcholine produce bronchoconstriction. Bronchoconstriction. So we are going to use anticholinergics. Anticholinergics to prevent the bronchoconstriction. So we're going to promote the bronchodilation, the anticholinergic. Okay? And they are going to dry secretions. Okay? Dry secretions because everything, saliva is acetylcholine, cholinergic, right? Anticholinergic now is going to do the opposite. Methylxanthines is really important, and you need to open eyes, open ears here. The methylxanthines is going to be, for example, the aminophylline. Aminophylline we are going to see in the next slides. Okay, and what is doing is the bronchodilation, and we are going to see some side effects that are really important for NCLEX. Okay, so I will tell you now. For example, methylxanthines, open eyes, open ears, are going to be the most common side effect are going to increase the heart rate. Increase the heart rate. So the patient is going to refer that as palpitations. 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 So it's the most common effect of the methylxanthines. Okay, so let's keep going. If there is any question, please just let me know. Just a moment. Okay, give me a second, please. Okay, thank you, David. I see you coming. All right, so here we are going to talk about all these medications that we already mentioned. All right, so just remember decongestant. So we have, what you need to remember is this: congestion, cough, and mucus. Congestion, cough, and mucus. Congestion. So you cannot breathe. You lost the sensation to smell, for example. Coughing. So what you're going to use, mucus. So there's three things in the upper respiratory tract. All right, so in the lower respiratory tract, we are going to use mostly anti-inflammatories and bronchodilators. All right, so let's keep going. The common cold is treated with empiric therapy, which means the medications only treat symptoms. That is what it means, empiric therapy. Empiric therapy. In the upper respiratory disease, we are going to see very brief the rhinitis. Rhino means nose, okay? Inflammation of the nasopharynx. And there are going to be two main concerns here, allergies and medicamentosa, rhinitis medicamentosa. That is what is coming for NCLEX, the medicamentosa, and some nursing considerations that I'm going to mention in the next few moments. All right, so rhinitis, I'm not going to go into too much definitions, but straightforward, we need to say that allergic rhinitis is caused by some allergens, right? Pollens, grasses, and what it's going to do is activating the mast cells, who are going to release, what they're going to release? Histamine. And when they release histamine, what we need to do is to give antihistaminics. Questions for NCLEX. If you know that you are allergic to pollen, for example, you go to Napa during the spring, or you go to some area where they have a lot of pollen, or even here in San Mateo where you have a lot of rain and then suddenly come a lot of sun with a lot of wind, all this dust is coming all around. So what you should do? So when you're taking antihistaminics, if you are going to go somewhere that you're going to have contact with those allergens and you know you're going to have rhinitis, you need to take it at least 45 minutes before. Antihistaminics at least 45 minutes before the contact with the allergens. Okay? All right. So a patient presents with runny nose, sneezing, congested throat, chills, and fever. What chemical in the body responsible for these symptoms is going to be the histamine. Remember when we are sneezing, we said histamine, histamine. All right, so going into this, first of all, I want to make two considerations about antihistaminics. Number one, preferable not to give to kids less than 2 years old. Why? Because antihistaminic has, and please write it down this, the antihistaminic can have a anticholinergic effect. Anticholinergic effect. So histamine, yes, histamine can produce an anticholinergic effect. So what they are going to do is to make dryness. It's going to dry the mucus. If you are secreting mucus, you don't want the mucus inside your respiratory tract. Why? Because they can be a culture for bacteria. So if you take antihistaminics and you don't take water at all, they are going to dry, and this is by sure create at least a bronchial infection. Okay, it can lead into pneumonia. All right. So what is the treatment for allergic rhinitis? The goal to prevent relief. All right. So you can take fluids, antihistaminics, glucocorticoids are going to be, it always is the next level. Glucocorticoids, we don't want to abuse glucocorticoids because they have several side effects. They can increase the glucose in blood. They can have some problems with the glucose. And actually, look at this. There's some. Just a moment. I have some problems with the audio. Okay. And glucocorticoids, they have many side effects. As we already talked, we have, for example, the increased gastritis, okay, can produce, diminish the immune system, okay, and we will see that in next slides. Okay, so, all right, so another NCLEX, please. Here's, I'm going to put big star here, big star. And here you can tell that you have some medications that is producing rhinitis medicamentosa. What is rhinitis medicamentosa? For example, you have nasal sprays, okay, nasal sprays, and mostly they have, for example, alpha-1. If you are congested, imagine your nose totally congested. You have this alpha-1, right? So that is the definamine is going to be an alpha-1 agonist. They are going to produce vasoconstriction, and that is mostly immediately the effect, right? The relief. But if you use open eyes, open ear more than 5 days, you are going to have what we call the rebound rhinitis or the rebound effect. The rebound effect. So that, what does it mean? That means that if you take the spray you're using right now, you feel relief. And then after half an hour, you are going to need it again. And you're going to just use it again and again and again. So I saw people who is using this for every 5 minutes. So they become totally not addictive, but dependent of this medication. Okay, alpha-1s. Okay, nasal spray. So don't use it more than 5 days. If you use it more than 5 days, you're going to have that rebound effect. So be careful with that. When a person uses a topical decongestant frequently, then stop the drug and notice even more congestion occur, that is going to be called the rebound effect. Okay, so that is what we are going to prevent, the rebound effect. So what is the treatment of a rebound effect? So when you have the rebound effect, mostly what you need to do is to stop the medication. But you say, well, my nose is congested. Well, it's just part of the process. We mostly give corticoids after that. It's the second level. So corticoids is not going to be an immediate action at all. They are going to take about minimum 4 to 6 hours to start to have some effect, but it's going to take full effect in about 1 or 2 days. So those 1 or 2 days, you're going to be totally congested. So, but this is the only way that we can get rid of the rebound effect. All right, so let's talk about a common cold. And the common cold, I know that you are doing in MedSearch your rhinovirus, coronavirus, influenza virus, adenovirus. And here we are not going to talk about that, but one thing here, common cold is the same to say coryza, is other name that is in the literature. All right, so mostly viral infections, you can get a cold for about, you can, if you're let's put it lucky, you have probably, you can have 7 or 8 times cold during the year. Okay, and that means that these viruses are not the same, are totally different viruses. Okay. All right, so signs and symptoms of common cold. So every rhinorrhea, you must know this this definition: runny nose, cough, watery eyes, sneezing, itching. Itching is because of the histamine. Congestion, we already explained that. Headache, because that headache is mostly a like a pulse in the head, and that is because the vessels of the scalp are going to produce vasodilate. Earache, malaise, and always again NCLEX question. Something that NCLEX question is trying to see these signs and symptoms. When they ask you about that, they ask you always about anosmia. Anosmia. What is anosmia? Anosmia is very simple. You cannot smell. You lost the taste. So that is one of the signs and symptoms of common cold. Anosmia. Don't forget about the word anosmia. All right, so treatment. So please open eyes, open ears here. The most effective treatment for a cold, common cold, is going to be the decongestants. Decongestants, okay? Antihistaminics are going to be some benefit, and actually I want to tell you something really important about antihistaminics. So remember, we have H1 and H2, okay? H2 histamine receptors are in the GI tract, stomach, right? And histamine 1 are in the rest of the body, all right? So this, when you have, for example, what happens when you take an histaminic? And this is always NCLEX question, please. This is the cell, okay? And this is the mast cell, Here we have the histamine receptor, And what it's doing is the antihistaminic to block this receptor. When they block this receptor, the mast cell cannot release histamine. Sounds simple, but definitely I want to tell you this. So some people think that, and it's not true, that antihistaminic is going to block the histamine that is already running in your system. And it's not true. So you have already histamine running in your system, and you take antihistaminic. The antihistaminic is not going to block the already produced histamine. What they are doing is to block the future of the production of histamine. So that is telling you this. So that's why the prevention is important. Why? Because if you take antihistaminic at the time you have the allergic reaction, it's not going to be so effective. It's going to be more effective if you prevent the release of the histamine. Okay, if there's questions, please just raise your hand. Okay, so other ones are going to be analgesics. You have headaches, right? Antipyretics, that is actually caused by the virus. The virus do not produce high temperature, but still fever. Expectorants, antitussive agents. So we are going to use antitussive. When we are going to use antitussive, expectorants, okay? Expectorants is going to be the guaifenesin, antitussive to block the coughing, right? And when is that? When you have a dry cough. If you coughing with dry, if you're coughing and it's dry, so you cannot produce anything. It's dry cough because it's irritation of the mucus of the respiratory tract. Okay, that is going to produce bleeding because the mechanical forces are going to make some vessels break. Another thing is that the patient cannot sleep. If they cannot sleep, they are coughing too much. They are going to use some antitussive. All right. So let's keep going. So the treatment is going to be about a week. That is the time that the virus is coming and go, right? So here, just to mention few things here, and very short. So what are the complications of the upper respiratory tract infections? Everything that is going to, if you're not treated, you know, the nasopharynx, the oropharynx are going to be are communicating, have communication between them, right? The nasopharynx, so we have the sinusitis, we have the sinuses, right? The paranasal sinuses, the frontal, the maxillary, sphenoidal, and ethmoidal. Remember in anatomy physiology. And these, when you have the virus in the nasopharynx, these they can get into the sinuses, producing sinusitis. Please, for your med search, you need to remember that sinusitis, one of the first signs of sinusitis is facial pain. Facial pain. Facial pain. I will show you in class how you just touching where are the sinuses, and if you have a palpation, some pain, that means that probably is going to be a sinusitis. Otitis media, remember the eustachian tube, go to the ear, to the middle ear. The nasopharynx connected to the eustachian tube, and that infection, if you don't treat it, they can reach the ear, producing otitis media. Remember the middle ear, and they can produce exacerbations of obstructive lung disease like asthma, So a simple cold can lead into exacerbations of asthma if you don't treat the cold properly. So that is actually very important. All right, so that is about the complications. A patient is experiencing a severe headache and pressure over the eyes. The patient feels congested, has no temperature, okay? Congested, has no temperature, elevation, and there is history of sinus infection. Which agent the nurse anticipate the healthcare provider might order? So antitussive? No, because I don't see the patient coughing. Expectorant? So what is the key word here? Is the congestion. So what you're going to do? Decongestant, alpha-1, okay? The phenylephrine. Phenylephrine, Sudafed, and all those guys are going to be decongestants, are going to be alpha-1. What is doing alpha-1? Vasoconstriction of the vessels. All right, so let's keep going. Here we have the sinuses. You see here the infection start here, but they can go to different parts as a complication, and that is going to be something that we need to avoid. Okay, so please remember always a lot of fluids, Normal ear, some fluid, and effusion of fluid. So that is effusion. It's coming. This is the tympanic membrane, and you can see there is some actually fluid in the middle ear that are actually going to push the tympanic membrane. So first thing you're going to have is diminish of your hearing. Why? Because the tympanic membrane become tense, and the vibration is going to diminish. Okay, so patient education and health promotion, we need to just remember that hydration is so important. Hydration, please. Hydration is main thing. Why is the hydration doing? Because they are going, even you don't need to take guaifenesin in order to have a good hydration, and the good hydration, what is going to do is to dilute the mucus. And that is going to be easier to get rid of. All right, so here we have, we need to please pay attention to this. I put 1.5 star. Okay, let's put it this way. Important. Proper temperature and humidity to prevent irritation of the nasopharyngeal mucus. So proper temperature, and you don't want to have too cold. It's not too cold outside. It's not too hot outside. You need to have the environment some humidity. Why? Because if you have a dry environment, the mucus become dry, and that can produce bleeding. Okay, so let's see. 94-year-old patient has severe dry cough. He has coughed so hard that the muscles on his chest are hurting. He's unsteady on his feet and slightly confused. Which drug would be the best choice for this patient's cough? So remember, dry cough is the key word here. So in this case, we are going to use whom? The dextromethorphan. All right, so alpha-1. In alpha-1, we have the phenylephrine. So this is what we need to remember. Phenylephrine, alpha-1, vasoconstriction. That's it. So we have a faucet here who actually is going to decrease the secretions, etc. So we have here the vasoconstriction alpha-1 phenylephrine. Okay. There is other side effects. So please, nursing consideration, NCLEX here, we are going to see that if this alpha-1 produces vasoconstriction, but if they can go into the systemic circulation, if you exceed the medication, if you go to the systemic circulation, produce vasoconstriction, that means that you're going to increase the peripheral resistance, and that is going to increase your blood pressure. So hypertension, contraindications. Okay? All right, so let's keep going. All right, so before administering another energy, decongestant is most important for a nurse to assess the patient for history of diabetes mellitus. Why? Number one, the alpha-1. They are going to increase the glucose in blood. They are going to increase the lipolysis. They are going to increase the triglycerides. So, but I want you to remember only just the glucose. Okay, the glucose are actually going to be increased with alpha. In corticoids too, we are going to see later, the corticoids produce the gluconeogenesis, increase the glucose, right? So here we have, be careful with patients with diabetics and using decongestants, especially who contain the phenylephrine or alpha-1. Beta-2 agonist or beta-2, what is going to do is bronchodilation. That is what we need to remember, the bronchodilation. This bronchodilation is, first of all, beta-2 is going to produce, is no selective. What does it mean, no selective? So I'm going to put agonist to make a remark, agonist. So if you have beta-2 agonist, this is no selective beta-2, they can produce beta-1 agonist effect. So what is beta-1? Remember the heart, right? The heart is going to, one heart, two lungs, remember? So one heart, beta-1, if you have excess of beta-2 agonists or overdose of beta-2 agonists, they are going to produce actually increase of the heart rate. If you increase the heart rate, what happened? You increase the blood pressure. We are going to talk about physiology and another time of the heart as a review. Okay, so that is what is the typical medication for beta 2 is the albuterol. 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 Albuterol is a short-acting albuterol. Remember that. Why is important to know short-acting albuterol? Because they can use in acute process, in acute process, in acute process. You're not going to use LABAs. LABA is, for example, the salmeterol. Salmeterol is a long-acting beta-2 agonist, but it's going to take longer time in order to make effect. But for crisis and most immediate results, you're going to use the albuterol. Albuterol. All right, so I'm just doing remarks about that. So, and that is what we really need to remember. So here's a summary of all what we was talking. Antitussive, we have opioids like codeine, for example. Codeine can actually, that is under prescription, right? It's a Schedule 2. And they are going to hydrocodone too, hydrocodone, that is an opioid. They can have antitussive effect. But this is not a topic today. So what we just remember antitussive is the dextromethorphan. Mucolytics destroy the mucin, make it more fluid, the mucus. Expectorant-guafenesin is going to bring more water into the mucus. It's going to be easier to get rid of that. Antihistaminics, first generation. So here in antihistaminics, NCLEX question, very important, is to have the consideration if the patient is doing some activity during the days. So what you need to do is to tell them, well, don't take the medication if you, or don't do this activity if you're going to do antihistaminics because you're going to fall asleep during the driving or using the machine, right? So we need to be careful on that. Antihistaminics, everything that is itchy sneeze, right? Rhinorrhea, itchiness, lacrimation. Decongestants, we have oxymetazoline, that is Efrin, that is over the counter, and that is actually alpha-1. Phenylephrine, neocephedrine, so those for congestion, okay? That is going to be the decongestant. Inflammation, corticoids, we have beclomethasone, those are prednisone, bectamethasone, dexamethasone, some are actually glucocorticoids. So one thing you need to remember about glucocorticoid is the nasal spray. Nursing consideration about nasal spray is burning. So don't wait until the burning is happening. They'll tell the patient before it's happening because they are going to feel that they're not the right medication. Mouth stabilizers are going to be the cromolyn. You need to get familiar with this. Mast cells, cromolyn. What is stabilized? Stabilize the mast cells. So the mast cells have receptors for allergens that are, when they are going to be activated, release histamine. So they are going to stabilize. So they are going to make like the receptors not respond to the allergy. Okay, mast cell stabilizer. Leukotriene is the leukotrienes are going to be the serfilucast. Montelukast is the most common. Montelukast. All of these are going to use for long-term treatment. Long-term treatment. To prevent. If you're going to use for, especially the mast cell stabilization, leukotrienes, for acute, they're not going to make any effect. Glucocorticoids, yes, depends what is the route. IV or IV mostly is very fast, but when you do a spray, these effects are going to take longer. So it's going to take a longer time to make effect. Okay, bronchodilators, we have the albuterol. It's a short-acting, and salmeterol. Salmeterol is the LABA, long-acting bronchodilators. So why I'm saying all these names? Because so many questions about NCLEX. and you need to be familiar with these names, okay? So I don't want you to find a name that you never heard before. All right, so here we have alpha-1 oxymetazoline is the prototype medication. We already said what are the nursing considerations. This alpha-1 can have, where is it? The rebound congestion. Rebound congestion. Be careful, no more than 5 days. No more than 5 days, please. And then we have possible adrenergic effects. They can, there's alpha-1 vasoconstrictions. They can go systemically, can produce hypertension. So you need to be careful with patients with hypertension, okay? All right, so about MAO and all that, we are going to make, there's no time to talk about that, but definitely we are going to have some extra time in the next few days. Okay, so the way to give the the nasal spray is this. Check, right? No like this. No with the patient laying down. Okay. All right. So that is going to make a lot of pain on the patient because of the drops itself. Antihistaminics, we have first generation, the phenylephrine. So remember, bed, take you to bed because you are sleepy, you are drowsy. And what is doing the phenylephrine? Dryness. And it's the word here, Benadryl, dry. So what you need to do is increase water on the patient, period. Second generation, we have the Claritin, the Zyrtec, the loratadine, and the ceftriaxone. So better pharmacodynamics, better pharmacokinetics, and we don't need to repeat that. We already know. All right, so okay, so open eyes, open ears. Most common side effect of the antihistaminics is going to be drowsiness and the nursing considerations that are going to be coming with. Okay, they have, in addition, anticholinergic effects. So I repeated this twice, please. Anticholinergic effect. Who is this? The antihistaminic. Antihistaminic have anticholinergic effect. So dry mouth. What is your nursing consideration? Increase water. Okay, so what is the action of the antihistaminics? Block production of histamine, create drowsiness to mask symptoms, occupy the receptor sites of histamine, prevent nasal congestion. What is the best answer here? So the best answer here is that it's going to block the production of histamine. Okay, block the production of histamine. So that means the antihistaminics are not going to block the already histamine going through your body. So if you have already histamine and you take antihistaminic, it's going to take a while. But if you prevent, even before you have the signs and symptoms, probably you will not have signs and symptoms of congestion. Okay. All right. So this is the first generation. Second generation, they have the most common chlorpheniramine. That is the grandpapa of all the antihistaminics. We have another one that diphenhydramine, Benadryl, very common to. Even in English, they give you sometimes this is so common, they give you the generic and the commercial name. Diphenhydramine. So this is, you must remember, that means the Benadryl. And the second generation that we already talked. Okay, so just remember what is the main side effect I want you to remember is drowsiness. Before administering antihistaminic to a patient, it's most important for a nurse to assess the patient history of which condition? Chronic urticaria. What is urticaria? Urticaria is eczema of contact. For example, when you go to the forest and you have this poison oak, yes. Or, well, I don't know, these plants that produce urticaria produce itchiness, redness, and pain. Motion sickness, when you are going to Caribe in your some cruise, Urinary retention, insomnia. So what we are going to have here? Antihistaminics. So we already know that antihistaminics have an effect of anticholinergic effect. Anticholinergic effect, remember giant cat produce contraction of the muscle, right? So the opposite, anticholinergic, is going to produce the no contraction of the muscle. So we are going to have the urinary retention. Urinary retention. Okay? All right. All right, so mostly, mostly one thing I want to, before I forgot here, is this. We have the decongestants, so please remember this. I'm going to put 3 stars. Okay, 1, 2, 3. Decongestants, and you have the nasal spray, nasal, and PO. All right, which one is the one who produce more rebound effect? The nasal, very good, the nasal spray. So PO do not have that rebound effect. So that is just keep in consideration, okay? All right, so let's keep going. Anti-inflammatory, we have, that is, for example, when we are going to use for what? For asthma, etc. Asthma, asthma, atelectasias, COPDs, etc. So anti-inflammatories, corticoids, they can lead into nasal burning. All right, so golden seal, the golden seal. So please, this is important. Golden seal is used for common cold, okay? But there are some contraindications. Contraindications are going to be careful with ulcers. Golden seal, ulcers, why? Because if you take any medication to decrease gastric acid, those medications are going to lose effectiveness. Of the medication to decrease the gastric acid, right? Lose effectiveness. Pregnancy, golden seal, golden pregnancy are going to produce uterine stimulant properties. So they can produce some contractions of the uterus. You don't want that. And for hypertension. So hypertension, please, open eyes, open ears. This guy, golden seal, looks like, but anyhow. So they are going to GI tract, pregnancy, and cardiovascular. GI tract diminishes the effect of all the medications for decrease the gastric acid. Don't use in pregnancy because produce uterine contraction and hypertension. So they can produce vasoconstriction. Okay. Okay. So let's keep going, and I going to. We already mostly talk about the most important things that I want you to remember. I'm going to make a small review here. All right, so please, what is the center of cough? Is the medulla oblongata. What is the main side effect of the antihistaminics? Drowsiness. What is the rebound effect? Please, rebound effect is the same to say rebound congestion, okay? And rebound effect is going to be mostly by nasal sprays. It's not going to be seen as much in the PO per mouth, okay? When you're taking guaifenesin, what is guaifenesin? It's an expectorant, right? To bring water into the mucus to get rid of the mucus. So, what is your nursing consideration? Take fluids. Don't take guaifenesin and wait for magic results. You need to support that with taking fluids. When you take excess of decongestants, what is the main side effect? The main side effect of decongestants are going to be the alpha-1 effect. That means heart rate increase. So that means the patient is telling you, I have palpitations. Palpitations. That is the main side effect. All right, so when you have excessive mucus, that is the moment where you're going to use the guaifenesin. Don't use nasal spray decongestant for more than 5 days. Why? Because you have the rebound effect. We have the golden seal that we already talked about that. The echinacea is another medication that another over-the-counter herbs that is going to boost your immune system. How we are going to assess all these medications, especially when you're talking about anti-inflammatories and bronchodilators. Bronchodilators, you must tell me the albuterol. Anti-inflammatories, you must tell me corticoids, mast stabilizers, leukotrienes. Those are the names that you must be familiar. And how you're going to assess the effectiveness of these all medications, just to see if the patient having an easy breathing. All right, so we have the methylxanthines that I need to mention here. Methylxanthines is a bronchodilator. So methylxanthines, we have is a bronchodilator. We have anticholinergics, we have beta-2 agonists, and we have methylxanthines. Methylxanthines is the I'm going to write it down here. Methylxanthines are the theophylline, the aminophylline, and these medications have one very common side effect. Side effect is going to be increased heart rate, means palpitations. The patient is going to refer as palpitations. Okay, so let's keep going here. We have the indacaterol. Indacaterol, we have that is a beta adrenergic, beta 2, that is ultra long acting. Okay, that is going to be used once a day and make effect in about 5 minutes. So that is one of the. It's not already the latest because it's 2009. It's like 6 years ago. Anticholinergics, we have the tiotropium. So remember what is the effect of the cholinergics? So now tell me what is the effect of the anticholinergics, right? Cholinergics, wet. Anticholinergics, dry. So that is in few words, okay? Okay, so we have the something here. All right, so one thing I want to go to the corticoids is this. This is a must. You must know this. We have anti-inflammatory, anti-allergenic action of the glucocorticoids, immunosuppression. So the white cells are going to be like fooling around because they don't know what to do. Increase blood sugar, glucose. Do not. Oh, this is very important too. So the corticoids are not used for pain. Pain? No, no pain. No use for pain. Right? It's anti-inflammatory. All right, so the steroid tapering. Oh, this is important, please. And I'm going to use a few more minutes. I know that it's 11 p.m. already. Steroid tapering. Steroid tapering, first of all, we have cortisol. I'm going to be very brief. Cortisol, stress hormone. This is morning, this is night. Okay, PM and AM. Cortisol is going to go up in the morning and go a plateau and then decrease at night. And then it's going to go up again in the morning. Why? Because cortisol in the morning increase the glucose in blood. So that is used for energy. That's why we use it in the morning. Okay, so now this cortisol, if that is going to make you awake, right? If you have cortisol, if you overstress, cortisol are going to be always very high. and that is going to make you have insomnia, right? All right, so more on that. So in order to prevent, because listen, if you make exhausted the adrenal gland who produce cortisol, there is a moment that if you use too much cortisol, if you have too much cortisol, here using cortisol is going to be high, 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 high. So the adrenal gland is going to say, oh, I don't need to do anything, okay, because I have enough cortisol, right? I have enough cortisol. And the hypothalamus said, you don't need to make more cortisol adrenal gland. Why? Because you have cortisol, so because you are taking cortisol as a medication. So what happens if you stop suddenly? If you stop suddenly the cortisol, the adrenal gland and the hypothalamus they need time in order to reestablish the new situation. So if you stop suddenly, your cortisol levels are going to be always low, and you will feel like 100 years old. So you will feel totally weak. So that's why we need to taper the steroids. Taper the steroids. And here we have what we need to remember. The corticosteroids are going to be 2/3 of the dose before 9 a.m. So that means in the morning. And 1/3 of the dose late in the afternoon. Why is that? Because you are trying to simulate the rhythm of production of the cortisol. So when you are going to you're going to stop the medication, you are not going to be affected. Okay. Now, if you don't, if there's another alternative, if you have 66% in the morning and 30% in the afternoon, but you want to take one dose only, in this case, you're going to use only in the morning. Don't use it at night. Okay, don't use it at night because you're going to be awake for a few days. Okay. All right, so mineral corticoids, this is another topic, but we have aldosterone that we are not going to mention at this moment. Okay. Okay, so leukotrienes, what we need to remember here is that they are going to make effect 1 week. This is the latest one, 2 hours, but the most common is singular, montelukast, that is going to make effect in 1 week. And you need to take every day. Otherwise, it's not going to make effect. All right, so anti-leukotrienes, they are going to use for if the steroids are going to work. Phosphodiesterase, they produce bronchodilation in the roughly mulast. Okay, so nausea, vomiting, diarrhea. So that is so they're not going to ask you that because these latest medication have less side effects. The immunomodulator targets immunoglobulin E. The immunoglobulin E is released for the plasmatic cells during allergies. And that is going to be the omalizumab. So it's expected to decrease the frequency of asthma exacerbations. So all these latest difficult names are mostly taking effect in a week or 2 weeks, and they are going to be mostly used for prevention. Mass stabilizers, we have the mass cromolyn. So please, I want you to review your masses, to be familiar, please, with the names and the group of the medication. All right. So if any question, please, I'm going to open microphone. Just a moment. Where are we? Oh, here. Okay. I'm going to open microphones. Just a moment, please. Mainly, Liu, can you hear me? David, can you hear me?
Yes.
Okay, so any question or any observation, let me know, please. The Pica, Solimar.
Yes.
Okay, so any comments, please just let me know. Just email me, or if there is something I can do, we can modify, just let me know. All right, so mainly, thank you so much for coming. Solimar, thank you so much for coming. Mr. Pica, thank you so much. And Mr. David, muchas gracias. I will see you next. We are going to see at 7:30 on Friday, right?
Yes, I'll be there.
Yes.
Okay, so I'm going to, this is recorded, so I'm going to post it in the Gap channel, and I'm going to send the link to everybody. Thank you so much. Have a good night.
Good
Thanks,
night.
Dr. G.
Thank you, Dr. G.